So, hello everybody. We are here for the third session of the late-breaking trials. So we have 6 speakers for you, so 6 late-breaking trials. And we start with one of my co-directors, Jan. And you're going to talk, Jan, about the ex vivo machine learning impedance analysis for thrombus analysis in patients with occlusive lower limb PAD towards improved diagnostic precision and treatment selection. The title is almost 5 minutes.
Yes, it's done. So let me to summarize a little bit. It's about insight about eSEPARATE study, in vitro study, you are right. So keep in mind that today to treat acute limb ischemia, mechanical thrombectomy and thromboaspiration could be used as a routine practice to treat this patient. But we know that a clot is not just a clot. We can have fresh clot, old clot. We can have some sarcoma, trilemixoma, white thrombus. So to be successful in terms of thromboaspiration or in terms of mechanical thrombectomy, the clot should be defined. It's why the impedance technology could help to define, in fact, the quality of the clot. Why? Because, in fact, when you use electrical independence at low frequency, you can define the cell size, the density, and the shape of the cells. At the same time, if you use high frequency, you can define the cell membrane. And by using a trained prediction model, you are thus able to define, in fact, the cellular tissue content. And so, to do it, you can have a big machine, like a regular impedance machine. But in fact, to go inside the artery is not so useful. It's why Sansom developed a small impedance catheter. And you see here the device. It's a 2 millimeter length and the diameter similar to a 014 guidewire. So it's very small in comparison to the regular impedance machine. And so to use it, it's a Clotild device, it's a guide wire. We have a transmitter using Bluetooth system and to a medical tablet named Clovis. And the tablet is able to operate, in fact, the sensor measurement during the procedure. You should know that this technology has been used already with a first main use for neurological purpose and to define the quality of the clot for ischemic stroke. So we have some undergoing study with this device in men already. And so, of course, is to know now if this device could be also helpful for the acute limb ischemia for lower limb. It's why we developed the eSEPARATE study to define the feasibility of the Clotild sensor to differentiate tissue involved in PID. So we include patients with chronic PID with acute limb ischemia, and we harvest this tissue at the operating theater. In total, in this ex vivo study, we include 15 patients, 1 patient with acute limb ischemia, 3 patients with subacute, and 11 with chronic. 12 male, 3 female in this study. And so we are able to define clot from subacute lesion, clot from acute lesion, and we compare also with other kind of arterial tissue. And again, using this different clot and other this tissue, we train a model to detect if the tissue have more or less of 40% of red blood cells. And in fact, by creating this model, we want to define the quality again of the clot. And so we did it successfully. In fact, the prediction model has a strong discriminative ability to classify, in fact, the quality of the clot in terms of red blood cell content. But also, to confirm this analysis, we use a model already trained for cerebral, for ischemic clot, in fact. And we using the peripheral samples, we check if also it works. And definitely, the answer is yes. The prediction model trained on ischemic clot data accurately predicts the red blood cell content of PID clots. So to summarize, impedance measurement paired with machine learning can differentiate clot from other tissue types ex vivo with high accuracy. Independence measurement paired with machine learning can effectively provide information on the red blood clot content of clot for patients with lower limb PID. Time symptom onset alone does not reliably predict red blood clot content. And finally, impedance could become a novel objective tool to characterize clot composition, enhancing diagnostic precision and optimizing lower limb PID. And so the next step is to know if, in fact, in vivo, in human, it could work. It's why I call Koen for the next step of the eSEPARATE study, in vivo study. Koen.
Thank you very much, Jan. Thank you. Thank you also for this great introduction to my presentation. Actually, if I can have my slides instead of Jan's, I would be very grateful. So, yeah, of course, a fantastic theoretical model, a model that was, no, that's the wrong one, that was tested in neuro, in animals, and now also in cadavers. So, of course, we would like to see, we would love to see if it also works in our daily practice, PAD treatment practice. There we go. So with the same system, the Clotild smart guidewire system, these are my disclosures. But before I show you my experiences with Clotild, I noticed that more and more of these devices, you have the Clovis detector and now Clotild. Yesterday I was speaking about Oscar, so we have all these fancy names for the devices. But first, before I share my experience, question to the audience, the esteemed audience. Here you see a passage just independent of the case. One of our daily cases, an 018 guidewire advantage of Terimo is going through and through, supported by a Navicross. You see there, it's not so tight, but it's also not flying through and through. As you can notice, here there is also instant reocclusion. So the wire is hesitating a little bit, but then making a loop, and it's running through and through. Again, there's some resistance, and then through and through. And here you are nicely intraluminally injection through the catheter. So what to do in cases like this? Just start to dilate and create massive distal embolization, or using an expensive thrombectomy device to pass first and to clean up all the acute thrombus. This is a problem that we are facing almost every day. And I hope that, for instance, this Clotild smart guidewire system based on impedance spectroscopy can give us some more answers. I don't explain you anymore the device. Jan did this in a great way. And so based on all the data he gathered together with ex vivo, in vivo sample sizing, so the model was trained to detect clot of more than 40% red blood cell content. And so we try now with this device to predict in vivo what we are passing. And this was the separate study design. All kinds of occlusions were included, they were enrolled in this study, small study, just to test the safety and the feasibility of the Clotild system in a single-arm, single-center way, prospectively, with a DSMB, and also to differentiate probably different tissue types and to see if Clotild is able to predict thrombus. These were the primary and secondary endpoints. We enrolled 17 patients in this separate study, 3 acute, subacute, and chronic. So now we know this, but before this was not so clear. And I'm going to share you some cases out of this separate study. A 58-year-old female patient, claudication since 6 weeks, severe claudication. And so my suspicion of the lesion was really thrombus with an underlying culprit lesion. Here you see the lesion. So there was a stenosis proximally. There were also stenosis in the mid-SFA, and then you have a long instant occlusion, as you can see over there. So my prediction, based on my daily experiences, was fibrotic plaque and hyperplasia in the mid-SFA, and then more distal, as my wire was passing there quite soft, thrombus in the stent. So this was my prediction. I passed with a regular wire. I exchanged through a little catheter towards the Clotild guidewire, and then we did the measurements. Afterwards, I treated, because my feeling was, like I've mentioned over there, fibrotic plaque in the middle and clot in the stent. I did a thrombectomy passing first with the Rotarex, and then afterwards I treated everything with the DCB. So, but this was more based on my feeling, on the tactile feedback of the guidewire. So I was really curious to see if Clotild detected the same. And here you see the detection of thrombus, with the red blood cell more than 40% count. So I started distally because I exchanged the wire, and you can see the different positions of the wire. So as long as we were in stent, you have a huge detection of clot material, fresh clot actually, and then from the moment on I'm leaving the stent, pulling back the device, you see that there is no detection anymore. So this was for me a clear proof and a confirmation of what I thought to be confronted with, and that I did also the right treatment. As you can see over there, this was the final outcome without any distal embolization. A second case, very short, 65 years male patient, with clearly the story of an acute limb ischemia since 24 hours, a pale, cold foot. So fresh thrombus, no discussion about this. You see a full in-stent re-occlusion over a very long length. So I decided, based on my tactile feedback of the wire to do, and the story, of course, to do thrombolysis 24 hours, and then afterwards culprit lesion, additional DCB. Looking if Clotild is saying the same to me, look here, you see all the detection over the full length of the occlusion of more than 40% red blood cell clot. So again, a correct prediction, I would say. And you see here the result of the definitive treatment. To end just a final case, so because it's not always that clear, a 46 years old, 64 years old male patient, very unclear story, confused, 10 weeks, yes or no, in-stent restenosis. So this was the case that I showed you as a kind of introduction. You've seen how my wire was passing. And so I've mentioned, okay, this is not really fresh thrombus. I think this is not something to spend all my money on a Rotarex device, but I just go for plain old balloon angioplasty, DCB and bailout stenting. And so what was Clotild saying, here you see the detection. There was no detection of clot at all over the full length of this lesion. And this was the final result post-DCB treatment without any distal embolization. So I need to say, to conclude, that in the cases I've done, that there was almost a correct, in all cases, a correct prediction about the presence of fresh clot. So it agreed completely with the clinical findings of an experienced physician. Electrical impedance spectroscopy could be a novel, an objective tool to detect clot in CTOs and to guide physicians in daily decision-making processes. I thank you for your attention.
Thank you, Koen. Now I call Raphael Solers for the CASSIS study. What is CASSIS? It's not a first name, huh?
Hello, everyone. Thank you to the organizers to selected this study that we want to present here about the feasibility of digital twin technology for planning about exact and acrylic stents, named the CASSIS study. So this is my disclosures. So we start from the fact that nowadays, in the world, the treatment of carotid artery endarterectomy, stenosis is moving from endarterectomy to stenting. In the literature, the restenosis rate at 3 years is about 17%, and multiple risk factors has been identified as oversizing in stent diameter and length. So our idea was how to improve this result, and we performed a first study named CASSIS 1, where we would compare the the real implanted stent on the post-operative CT scan compared to the digital twin of the stent implanted on the pre-operative CT scan. To zoom in this technology, you can see here the digital twin of the carotid artery and the digital twin of the Abbott stent and the implantation of the stent in the digital twin. And on the right of the slide, you can see the post-operative CT scan. The aim of the study was to compare the distance between the bifurcation and the distal part of the stent and the diameter at the proximal and distal landing zone. And on the 50 patients that we analyzed, there was no difference between the real stent and the simulated stent, so we validated the model. Afterwards, we performed the KC2 study. So we selected 4 high-volume centers for Abbott carotid stents. Nélis Delascava from Hospice Civil de Lyon, Maxime Sibé from Clinique Saint-Augustin Bordeaux, Philippe Reyny from Vivarais Aubenas, and me. We all sent 5 CT scans to the platform and to PrediSurge. And the first step was the operators analyzes the pre-operative CT scan and select a stent, okay? Secondly, 2 months later, PrediSurge sent us a slide with the digital twin and the simulated stent, and we have to reselect another stent, and we compared the results. To see an example, that's the slide that we received with the digital twin of the carotid artery on the left and all the spectrum of the Abbott stent implanted in the carotid. And as you can see the impact on the stenosis, on the kinking on the top of the internal artery. So we have this element to select the stent that we want to use. For the results, we considered as a perfect match when the operator selected the same stent before and after seeing the digital twin. As a partial match, if there was at least one corresponding criteria and at least one not corresponding, and as a no match when there was no corresponding criteria. And as you see on this folder, you can see that there was a perfect match on 10% of cases, and there was a no perfect match in 90%. So to summarize, the digital twin technology can modify the stent selection by a trained surgeon in 90% of cases, as you can see by showing him the future kink on the top of the carotid, the dead space between the stent and the carotid wall, or the perfect apposition of the stent. And to move up and to improve our results, we decide to perform a new study named CASSIS Pro, where we will evaluate the clinical impact of the digital twin for the planing of Abbott Exact and Aculink stents. Thanks.
Thank you very much, Raphael, for this clear explanation. My pleasure to introduce Dr. Nicolas Inston from Birmingham, UK. You're going to present us the results from the UK VasQ registry for the creation of extravascular supported AV fistula. Please.
Thank you very much. Thank you. I'd just like to go through this study on the VasQ device, and that's my declarations. So what is the VasQ device? Well, this is an external scaffold which is placed at the time of surgery when we create a fistula, and this encases the fistula. Why do we do that? Because the principle of AV fistula maturation is that we want outward remodeling rather than inward remodeling in stenosis, and failure to mature is very common in fistulas. The likely pathophysiology is due to hemodynamic stresses and mechanical stresses together resulting in this. How do we correct that? Well, it's predominantly about the angle of the anastomosis, and the VasQ device provides this scaffold to support optimization of hemodynamic flow at the time of fistula creation, which should promote outward remodeling. The sizes are from 1 to 6. They don't correlate with actual millimeters. The 1 is 2 millimeters to 3.2 millimeters, and the 6 is bigger, 5 millimeters to 6 millimeters. We did this study because I was somewhat skeptical about this concept and also some of the data. So we did a study between ourselves and Paul Gibbs at the Queen Alexandra Hospital in Portsmouth. We'd put a number of these devices in, and we wanted to look slightly longer term. So we looked at follow-up over 6 months. And this was between November 22 and January 24. The outcome measures were maturation, first cannulation, interventions, and abandonment. There was a total of 58 patients, were included 33 from Portsmouth, 25 from Birmingham, slightly more males, male predominance. Median age was 62 years, and there was a slightly older group than some of our other fistula patients, and these were an unselected group. What I didn't want to do was say we can create excellent results just by putting these in patients that have excellent veins to start with. This was 40 brachiocephalic fistulas, 15 radiocephalic fistulas, and 3 brachiobasilic transpositions. The outcomes, we had 58 patients. 1 patient was lost to follow-up, but of those patients, 65% of them matured without any intervention. 13 patients failed, ultimately. 10 patients had a subsequent intervention, of which 7 were salvaged, giving an overall assisted maturation rate of 77%. Comparing this to the literature, essentially, we used 2 studies, 2 registry studies. One, the UK study, which had a 50% primary unassisted patency rate and a 59% assisted patency rate. And then there's also the American data showing a 67% assisted patency rate, but a 45% unassisted patency rate. Both series, our data reflected in favor of the VasQ device. It is a small study, but that's the situation. So really just very brief report here that in an all-comers setting, unselected patients, we did see high rates of maturation. Very few of the VasQs really needed additional maturation procedures. Compared to the reported outcomes in the UK, VasQ appears to improve maturation rates, and that data seems to be consistent across a number of smallish observational studies that have been done around the world, and showing that there is a benefit from using VasQ at fistula creation. Thank you very much.
Thank you. Thank you very much. So now my pleasure to introduce my course director, Dr. Malios. And Alex, you're going to talk about the nationwide observational study on the natural history of hemodialysis, AV access, and patient survival after an initial thrombosis. Please.
I will, Koen, and I'm afraid I don't have good news for you.
Oui.
As a vascular surgeons, I don't think we're doing very well our job. I think there is another specialty that is doing better. So let's see what we found. An extensive work that we did thanks to Boston Scientific and HIVA, who did all this work. It was basically a study that we used coding data from the national system of France to identify patients that had the fistula thrombosis and follow these patients up based on the coding system and see what happened with their fistula for 5 years after the index event that was a thrombosis of their fistula. What we searched to evaluate mainly, amongst other things, but the principal things were the patency of the fistula in 1 month, the patency of the fistula in 1 year, the abandonment or not of the fistula in 1 year, and of course the survival, overall survival of patients 1 year and 5 years after the index event, and also what factors were related with what outcomes. Regarding the demographics, nothing special, 60% male, and most of the fistulas, 95%, would probably be qualified as mature. And this is the meat of the presentation. So about 17,000 patients that had a fistula thrombosis and were followed up, as I mentioned, for 1 up to 5 years. And see what we had. So surgical, which means purely surgical or hybrid. And I know you will be surprised. You will say, who is doing this just surgical thrombectomy without doing an angiogram and balloon angioplasty in the end? You would be surprised. But actually, probably this is what's happening in most places. There may be a Fogarty and not necessarily fistulogram and dilatation of the culprit lesions at the same time. So surgery was the majority that happened, and you see that the results were worse. So in 1 month, 20% of patients lost patency for surgery and 13% lost patency for endovascular. Again, surgery meaning pure surgery or hybrid. We don't know the percentage between the two. and endovascular was purely endovascular, which means IR in France. In 1 year, this percentage was 42% for surgery and 27% for endovascular. And overall abandonment was 32% for surgery and 18% for endovascular. And all these were highly statistically significant. Regarding the confidence intervals between different factors, you will see that women did worse, surgery did worse, and of course, the more the patients were diseased, the worse the results we had. What about overall survival? Well, again, endovascular did better. So you will see that about 15% of these patients were losing them after 1 year, and about 50% of these patients will die in 5 years, meaning that if you go to a dialysis center, 50% of these people are not going to be here within 5 years. And these results are actually better than what we had before from a study we had in Germany, which was about 50%, I think, in 2 or 3 years. So again, endovascular seems to be doing better. Now, I don't know if this is related directly to the fact that saving the fistulas better, which is the lifeline of the patient, is basically leading to better survival of the patient, or it is reflecting that if this region of France has a better quality of health care, meaning they're providing endovascular care, so perhaps they're treating cancers better, perhaps they're treating their coronaries better, so there is a confounding bias there. But anyway, these are the results, and there seems to be that there is lots that needs to be done to improve our results. So, in essence, to conclude, this study, which I think is an original study, is giving us some important evidence, which is that patency and survival are not the best for these patients, and lots of improvement can be provided. And then the vascular approach seems to be doing better in 1 year and 1 month patency. And there's definitely something that needs to be improved when we surgeons are doing thrombectomies without doing endovascular work. Thank you very much for your attention.
Thank you, Alex. Impressive data, absolutely. So my pleasure and honor to introduce Caroline Caradou de Bordeaux. So you, Caroline, going to present us the LUMIFOLLOW follow-up multi-center prospective registry on the Luminor DCB and SFA and popliteal, more than 500 patients, and I would like to see the 2-year results.
Thank you for the kind introduction. So the LUMIFOLLOW Registry was about the Luminor DCB implanted in the femoral popliteal lesions. It was a real-world registry, so what's interesting is that we had quite extensive inclusion criteria. We had Rutherford category 2 to 5 patients. We went down to the P3 segment of the popliteal artery, which is quite unusual for DCBs in the randomized control trials. We had test 2A to D lesions, and we also had de novo and restenotic lesions, whether they were stented or not. In terms of recruiting centers, it was only in France, and we had 15 centers with 542 patients included at the start. And now we have the preliminary results of 351 patients at 2 years. In terms of baseline characteristics, those are the ones that you would expect for this kind of patients. So mostly male patients, 40% were diabetics, 70% were hypertensive. We had the popliteal artery involved in almost 40% of the cases. And like I said, restenotic lesions, 24%, and task C and D lesions in more than 40% of cases, with total occlusions in 44% of the cases. So quite complex lesions and patients. It's interesting to see that in France we switched to the 018 platform during this period, so almost 40% of cases of the superficial femoral artery were treated with an 018 balloon, and the remaining were treated with a 035 as usual. And in terms of stenting, you'll see that we had a high rate of bailout stenting, 43%, which is different to the ones you would expect in randomized controlled trials, but it's actually the same rates that you would expect in long lesions in real-world registries. And it's interesting to see that we had a shorter stenting length compared to the initial lesion length. In terms of early outcomes, we've published those recently in the JVS, as well as the 1-year results. So we had no safety concerns, and the acute efficacy endpoints were met. And in terms of 2-year results, we had a 9.6% of all-cause death, mostly linked to cardiac death or mesenteric ischemia or cancer. So no safety concern here with the balloons. We had, remember, critical ischemia patients, so 1.8% of major limb amputations, no additional minor amputations compared to the ones that we had next to the initial surgery. And in terms of TLR, we had a 5.9% rate. So the results were quite maintained compared to 1-year results. In terms of primary patency, we had an 87.4% rate at 1 year. It went down to 73.9% at 2 years. But if we actually look at the results of the IMPACT-SFA randomized control trials with more simple patients and lesions, it's quite comparable. And if you consider that we had a 40% rate of bailout stenting, it's also quite comparable to results of covered stents, for instance, the recent results of the VIASTAR study. In terms of TLR, like I said, not much more after 1 year, so 92% rate of freedom from TLR at 2 years. And in terms of clinical data, you will see that we had an acute success right after the procedure, and the results were actually maintained all the way to 2 years in terms of Rutherford category, and also in terms of walking impairment questionnaire for the claudicants, in terms of distance, in terms of speed, or also stair climbing ability. And as well in terms of quality of life improvement, especially in terms of mobility and in terms of improvement of pain or discomfort. So I think those real-world data results are quite important because they confirm the results that we had with the randomized control trials and also with the more simple and more simple patients and lesions included beforehand. So this drug-coated balloon actually has good results even in real-world patients with high primary patency rates. The only difference here is the high rate of bailout stenting, which is, I think, expected if you have those complex lesions, especially since we didn't have a lot of atherectomy devices at the moment because of reimbursement problems in France. Thank you for your attention.
Thank you very much, Caroline. And so with this, we can close the the third late breaking session. I wish you all a very nice lunch. And I would like to see you back at 1:30 or here in Le Nôtre for a carotid session or in the room Habriel for a CLTI session. Thank you.